Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. In order to consider uterine atony or subinvolution, we should first think about the uterus. The uterus is the muscle that the baby grew in and was delivered from, and after birth, the placenta is then also delivered. And the placenta was attached inside the uterus, and the placenta is about the size of a plate. So it took up a lot of surface area in there. And in that area, there are big vessels that were feeding and perfusing that placenta. After the baby is born and the placenta is delivered, the uterus must contract in order to control bleeding and squeeze those vessels. And this contraction of the uterus is also important to help the uterus go back down to its pre-pregnant state, which we call involution. So for uterine atony is going to be our number one cause of an early or primary hemorrhage that occurs in the first 24 hours after a baby's born. And this is actually at the greatest risk during the first hour. And so uterine atony is the uterus not contracting and not squeezing those vessels. So what we can see here is a boggy fundus. So if you massage the top of the uterus, instead of feeling firm and contracted, it can feel soft and squishy. Saturating a pad or more per hour, an enlarged uterus or deviation from midline. So after a baby's born, we anticipate to find the top of the uterus close to the belly button. And so if it's above that, then that's a sign that it's enlarged. And also if it's deviated from the midline, it should be in the middle. So if it's off to the left or right, then that can also be a sign as well. Vital sign changes. So tachycardia is typically our first vital sign change we see. As she becomes more hypovolemic, her heart rate increases to help circulate the remaining volume that she has. And as her hypovolemia continues, then we start seeing hypotension. So tachycardia is an early sign and hypotension is a later sign. And then we can also see other signs of hypovolemia as well. So management for uterine atony is going to be related to making that uterus contract. So massaging the fundus, managing the bladder. So with this, we are thinking about keeping the bladder empty. If the bladder is full, it puts pressure on the uterus that can decrease the contractility. And then we're going to think about medications that make the uterus contract, or uterotonics that improve uterine tone. So Pitocin, Cytotec, Hemabate, and methergine are the main medications we would use for this. We could consider surgical management or interventional radiology, where they can either cauterize the vessels or completely remove the uterus if we can't solve the problem. We can consider a Jada or a Bacary. A Bacary is a balloon that goes inside of the uterus and is filled with fluid to put pressure or compression on those vessels. And a Jada actually decompresses the uterus and it helps to control bleeding and make the uterus contract in that way. We're going to need to manage the fact that she's bleeding and hypovolemic. So we need 2 large bore IVs. We're going to be monitoring her vital signs. We can give oxygen so that the circulating blood is very well oxygenated, so we're perfusing the tissues. IV fluid, potentially blood products, and quantifying the blood loss by weighing the pads. We're going to be monitoring for signs of hypovolemic shock. So those vital sign changes, the tachycardia, the hypotension. We can see a decrease in urine output because she won't be perfusing her kidneys well. We can see mental status changes, pallor, and cool, clammy skin. For subinvolution is going to be the cause of a late or secondary hemorrhage. And this occurs after those first 24 hours up to as much as 12 weeks after the baby's born. And subinvolution is the failure of the uterus to return to its pre-pregnant state. So involution is returning to the pre-pregnant state. Subinvolution is the failure to do so. So the greatest risk for subinvolution is going to be infection, like endometritis inside the uterus, or retained placental fragments that are keeping that uterus from contracting down. For signs of subinvolution, one of the big signs would be the vaginal bleeding or return to rubra. So the normal lochial process or discharge process after delivery is to have lochia rubra that goes to serosa and then goes to alba. If we go from rubra to serosa and back to rubra, or if we just have delayed rubra where we're not making that transition, those are signs. An enlarged uterus. So we anticipate with normal involution, we anticipate the uterus to be going down about a centimeter a day. And so if it's not doing that, then it's enlarged. We can see pelvic pain or tenderness and signs of infection if she has an infection that's causing her subinvolution. So she might have a fever, foul-smelling discharge, and those things as well. For management, we're going to monitor the uterus to see if it's enlarging further. We're going to monitor her bleeding. She might need a D&C, which is a dilation and curettage, where they have to clean out retained placental fragments. And then she might be on medications to help her uterus contract. So again, those uterotonics, Pitocin or methergine, and then antibiotics if she's infected also. So when we compare the two side by side, uterine atony is the failure of the uterus to contract after delivery, and this is causing significant bleeding. Subinvolution is the failure for the uterus to return to its pre-pregnant state. For uterine atony, the onset is the first 24 hours after the baby's born. Subinvolution can be days or weeks after delivery. On assessment with uterine atony, the fundus is boggy, the uterus is flaccid, and it can also be enlarged. With subinvolution, we also have an enlarged uterus, and it may be soft or it may be firm. It might still also be above the umbilicus as well. Signs and symptoms of uterine atony include heavy bleeding, vital sign changes, so tachycardia, hypotension, blood clots, and a uterus that's not firm even after massage. With subinvolution, signs and symptoms include light or moderate bleeding or either that persistent rubra or return to rubra, enlarged uterus, and not where we expect to find it, or that delayed return to normal size. And then we can also see pelvic pressure, uterine tenderness, depending on the cause. Nursing actions for uterine atony, fundal massage. Massage the fundus. Try to make that muscle contract. Uterotonics are medications that also help the uterus contract. IV fluids, monitoring vital signs, monitoring signs of hypovolemia. Nursing actions for subinvolution is going to be monitoring the lochia and the size of the uterus and reporting if it's increasing. Potentially giving the medications, uterotonics or antibiotics as ordered, and then being assisting and supporting for a D&C if it's indicated. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.